we have this panel here, a panel discussion on the reproductive and sexual health, the key challenges and solution for India adolescents. So for this, we have moderator, Dr. Kiran Pandey ma'am, and co-moderator, Dr. Pavika Lal. So we have Dr. Kiran Pandey ma'am, who's the ex-HOD, and she is Professor, Department of Obs and Gynae, GSVM Kanpur, and she is ICOG Governing Council member 2021-22. Then the co-moderator, Dr. Pavika Lal, is an assistant professor at GSVM Medical College, Kanpur, and I think we can quickly go through her CV. We can read it through because we would be saving time if I have to read it out. So coming on now to our experts, we have Dr. Ragini Agarwal. We have heard her. We all know her. We have all seen her working. And she is the Vice President of N.I.G.F. and she is President-elect of N.I.G.F. Other than the whatever we can read on the screen, she has been the Vice President of FOGSI 2020. And then we have Dr. Amritpal Kaur, who is the Professor, Head of Department, Government Medical College, Amritsar, and who's also President of AOGS. Then we have Dr. Meenu Vaish, who is Director Consultant at Meher Hospital, Dehradun, and she is also the President of Uttarakhand Chapra Obs and Gynae chapter. Then we have Dr. Mala Srivastav. Dr. Mala is also the Secretary General of N.I.G.F. So many congratulations actually to each and everyone in N.I.G.F. who has contributed and who has come and who would be coming. So my sincere thanks to each one, and God bless us, actually. So that is the only line I can just say now. Dr. Professor Mala Srivastav is a senior consultant and professor of GRIPMA, Sir Gangaram Hospital. She has been past president AOGD in 2021. Then we have Dr. Punita Gupta, who is Associate Professor, Department of Obs and Gynae, Acharya Shri Chandra Hospital Medical College, Jammu, and she has been a teacher for the last 16 years with special interest in high-risk pregnancy. And the finalist, the last but not the least, we have our own Dr. Anita Rajoria. We can read through this busy slide, and she is actually a chairperson of the Adolescent Committee of AOGD, and I think it would be better if we all listen to her, and I give over to our moderators, Dr. Kiran ma'am and Dr. Pavika ma'am. So I would be stop sharing and giving it over to you, ma'am, for the panel discussion.
Thank you so much for nice Dr. Jyoti. Yes. Am I audible, Dr. Jyoti?
Yes, ma'am. Yes, Dr. Pavika. You're clear.
No, I'm Dr. Kiran Pandey.
Yeah, Dr. Kiran.
Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. So, thank you, everybody. And really, it's extreme pleasure to be part of this first academia series. My great regards to Dr. Sharda Jain, who she has mentored this N.I.G.F. like anything like her baby, and our president, Dr. Sadhana Gupta, who has given me this opportunity to be part of this first academia series. And I cannot stop saying one word. It was an excellent lecture which she has given on adolescent PCOS, beautifully covered not only the things which to be done, not to be done was also very, very important. So I love that. And I think everybody has been benefited on that. Now, let's start with the panel discussion without wasting any moment. And as you all know, it is on the reproductive and sexual health, basically, which is the most important in present day time, key challenges and the solutions for the adolescent. So, is my Sorry.
Ma'am, I'm moving the slides.
Ma'am, the slide is not moving. It is only the first slide, panel discussion dikh raha hai.
Ma'am, I'm moving the slides. Hello?
Yeah,
Am I audible?
Yes, we can now see Kiran Pandey ma'am's, yeah, it's moving now. We are on to introduction.
Slide sharing. I am doing my slide sharing. I'm doing, Kiran Pandey ma'am is just talking. I'm doing the slide sharing. So is the slides moving?
Yeah, they
yes,
are.
ma'am. Yes, ma'am, it is moving. Right now we are seeing
Ma'am,
introduction.
please go ahead. Okay, ma'am, please go ahead. Ma'am, you're muted. Kiran ma'am.
Okay. Pavika, there might be a few seconds time lag because I am in US. So that just wait for a few seconds if ever the situation comes like that. So first I will welcome all my panelists, and in fact, very rightly said by Dr. Jyoti that they are all experts of their fields. So it is again a very important that way a landmark panel discussion. So as you all know, already told you, okay, nearly 35% of the global burden of the disease basically has roots in adolescence, as pointed out by Dr. Sadhana also. We all know that Baker's hypothesis, and that is the reason that we have to focus on here. We all know the age group. We all know what changes do happen in this period, not only physical, cognitive, psychological, everything. They are making the largest proportion. India being the young country, the country's 21% population of the world, it shares 21% of the world population, and we all know the specific problems which there are very important things. Today what we are going to discuss is which actually require awareness because they are less discussed. So that is early recognition to avoid the other complications, specifically the sexually transmitted disease and the teenage pregnancy. And there are menstrual pain disorders and menstrual bleeding disorders, about which we all know, and we know the importance. Presently now, I think in last few years, a lot has been talked about the menstrual hygiene also, which is important. So now let's come to Dr. Ragini. Are you there? So I would like, So I would like to know from you only. You are the opening batsman, not only of N.I.G.F but also of our panel also. So let's see, what does MHM stands for and what are its components?
Thank you so much, Dr. Kiran, for asking me this question, because the women intimate health is something about that I'm so passionate. Corona time, I have had a whole webinar series on this. We all know that the menstruation is a point, first menstruation when a girl turned into the womanhood. So it is a natural, normal, biological process experienced by all adolescent girls and women, but we don't spoke about it, causing unnecessary embarrassment and shame. Almost 113 million adolescent girls are vulnerable at the onset of menarche. They need a safe environment and offer the protection and guidance to ensure basic health, well-being, and educational opportunity that should be realized. But if there's no toilet, no facility, so it's a position when they don't feel dignified. So it is basically when we talk about the safe and effective menstrual hygiene management, that is what MHM stands for, is a trigger for better and stronger development for adolescent girls and women.
Very nicely explained, Dr. Ragini.
Yeah. So when we talk about this, just a 2 line more, Dr. Kiran, that we should know that it is the integral part of the Swachh Bharat Mission guidelines, and it is issued by the Ministry of Drinking Water and Sanitation to support all adolescent girls and women, and it outlines what needs to be done by the state government, district administration, engineers, and technical experts in line departments, and school head teachers and the teachers. Over to you.
Yes, so nicely not only explained but given the guideline also. And so to summarize, we can say one has to have access to the knowledge and information, access to safe menstrual the absorbance, water sanitation. As you said, the technical persons in the state government has to ensure that, and of course, access to safe disposal. So over to you, Dr. Pavika. You can take the next question.
Okay, ma'am. Thank you so much, ma'am. Sabhi ko mera pranam. So coming on to sexually transmitted infections, we all know that each year almost an estimated 374 million new infections occur worldwide, affected with infections. So what is the most common cause of STI in adolescents? The question goes to Dr. Amrita Pal Kaur, ma'am.
Thank
Is
you,
ma'am there?
for making me part of this program. I would like to say the most common bacterial STI in today's world is the chlamydia infection in the adolescents. And the second most common is the gonorrhea, and followed, though they are of different type, bacterial, fungal, or parasitic. And the girls, they do get the human papillomavirus infection at this time also. But the biggest problem with this is most of the cases, they are asymptomatic. And the symptomatic are only the tip of the iceberg. So we have to target the asymptomatic by screening and treating. And if we do not treat at the asymptomatic period, this has got lifelong reproductive, long-term complications with PID, with infertility, with chronic pain. So HIV, syphilis, there are other STIs, but the most common is the chlamydia with gonorrhea. Mostly chlamydia and the gonorrhea, they occur together.
Yes, ma'am, very correctly said. Over to you, ma'am.
Yes. Yeah. So
Over
basically, very rightly explained about the bacterial. So is Dr. Meenu is there? Because I think she is having she has become COVID positive.
So
is she here?
Cover this, ma'am.
Okay, so that anybody one by one can cover this. So what are the basically guidelines say about this ACOG and the CDC guidelines? What do they say about their
CDC recommends that all the sexually active women of less than 25 years, they should be screened every year. And for women more than 25 years, those were only the high risk women that having the multiple sexual partners, more than one partners, or out of marriage relationships, and those should be screened annually. And for men, if the men are having men having sex with men, they should be screened. Otherwise, the annual screening of the asymptomatic men is not recommended. And how you screen is by history taking and of vaginal discharge or perineal discharge or penile discharge with urinary problems of burning exhibition, frequency of exhibition, or even rectal discharge, rectal pain. These are the symptoms if they have the anal sex or oral sore throat and cough, so oral sex. So we have to go by the history and then take the swab from the vaginal swab or even from the urine. This can be tested at the point of care, also on site, whenever the patient comes, give it a test. Like that is the most commonly recommended test. But if it is not available, we have to go by the syndromic approach as we commonly don't have this test.
We discuss about that, Madam. I know you are very your experiences of the whole life is so much. That
Can I add something, Kiran? Can I add something?
Yes, you can add, Anita, but let's all be limited and because we have to
only
finish
one line to add, because we have to give focused attention to the victims of sexual assault, those survivors who are coming. Because even if there is an indirect evidence like they have genital warts or there is any other evidence, we must screen these young children and adolescents for these infections. That is the only thing I wanted to add. And when we are collecting samples for their medical legal examination, it is our utmost responsibility as care providers to screen for these infections and give them prophylaxis for these if it is already.
Yeah, so this comes into even the guideline when these sexually assaulted children do come. How do you have to take various swabs and all that. I mean, at the moment we are not going into it, but very nicely pointed out that this part has to be focused, Dr. Anita, very right. So let's start with the case discussion. And there comes this is a girl of 19 years old, and she had a history of a recent irregular bleeding. She's with her current sexual partner for 4 months and was recently stopped using the condoms. We have taken this case very simple one and the clear cut. So without going anywhere else, we'll be focusing on our topic only basically. So after taking her consent, because she was sexually active, it was found on examination that vulva, vagina, everything was healthy. There was no inflammation. Small cervical ectropion was there and profuse mucoparallel discharge. No tenderness on bimanual examination was there. So Dr. Mala Shrivastava, let's start with you. How will you approach?
This patient, she has a history of irregular bleeding. And she recently has been on regular sexual relationship. Now we have to take history whether she has taken any IPIL or emergency contraception, because she was not using any condom recently. So whether from the history we have to take whether she has been using any emergency contraceptive. That history is important and that can give rise to irregular bleeding. And secondly, we have to also see on examination, you have said she has mucopurulent discharge. We have to take the discharge for examination, culture, bacterial vaginosis, chlamydia infection, all sorts of infection that we can take and we can test. We should do that. And then we have to give the syndromic approach. And we have to treat this girl.
Dr. Mara will come to that syndromic approach. But at the moment, it's best to that. Like this patient is very often, I mean, they are asymptomatic also most of the time. So as you were very rightly pointed out, each and every point which was told to us in MBBS periods, the detailed history, and very nicely pointed out about the emergency pill, because these days they are available on the over the counter and anybody can take it. So one more thing, would you like to, supposing in certain cases you can't take they don't give clear-cut history, and can you take a swab from somewhere else also besides
we can take cervical swab and we can also take rectal swab.
Yeah.
Without any investigation. Yes. Because we have to, most of these girls, they may be asymptomatic and we have to catch these girls, because even if they are asymptomatic, they may be suffering from gonorrhea and chlamydia, which can have long-term effect on their health. So that is important. We have to catch these girls, treat them, diagnosis that has to be done, and treat them also. Besides, we should also try to catch their partners, because their partners may also be asymptomatic. And it's important because they are in a regular relationship. So even the girl may be asymptomatic, the girl may not be having any problem. If the partner is having problem, the partner needs to be treated. And because the partner may reinfect this girl again.
Yeah, very rightly pointed out. This point again, this can come only from the experts, that one should not ever miss the partner point. And you also have to be, she's a monogamous, or she's having multiple partners. And I mean, this has to be, can come out with a lot of confidence has to be established between the girl and the treating person. Only then she will be able to come out with these details. So that's excellent with it. Dr.
There is one more aspect, ma'am.
Yes. Can I add, Dr. Kiran?
Yeah.
These girls have to be told that even if you're treated, diagnosed and treated for STI, they need to be retested after 3 months. And they're
Test of cure.
Retested for after 3 months, because these infections can recur again and again. So,
absolutely.
Kiran ma'am, there is one more aspect. It is important to take history of partner. Like you said, she may be having contact with only one adolescent or one boy, but that boy may be having multiple partners. So it is, as Mala has highlighted, it is very important to screen the partner, and partner has to be screened for her. His partners also would need to be, if the confidence is there, you develop the rapport with the partner, then he should be also screened how many partners he has. So all this cascade screening has to be performed.
Yeah, so such important points have come out, and I think really, as I said before, then for this you have to really establish a great rapport with that person. Only then everything can come out. Otherwise, they will feel they will not come out, and we will miss the things. And rechecking, because evaluation is again very important points. So, Dr. Pavika, you can continue about the management.
Yes, ma'am. This question goes to Meeta Gupta, ma'am. What are the management strategies for ST in adolescents?
Thank you, Dr. Pavika. And at the onset, I would definitely like to first thank Dr. Sadhana ma'am and Shada Jan ma'am for giving us this opportunity to be part of this panel. The entire new organization, the North Society that we have, has been inaugurated today. So coming to my question, I think so the first and foremost would be awareness and, sex education that we have to give. Before anything, if any girl is coming to us with vaginal discharge, they have to be counseled regarding the use of barrier contraception. That, okay, because times are changing, sexual activity has become very rampant, and these kids are all trying to experience new things. But what they have to be made aware is about this use of barrier method. We cannot ask them not to go for any sexual activity, but what we can counsel them is proper sexual activity with use of barrier method. That is, I think so, the first and foremost thing as caregivers or health providers we have to supposed to take care of.
Sorry to interrupt, Dr. Meeta. I think the first thing should be their management and upkeep. Once we have developed that confidence and the problem is solved, then further we can take up these things in our...
Ma'am, I would just like to differ, because once we give them treatment, they will never come back to us. So you have to give us a little 5 minutes extra to counsel them for barrier method. Yes, treatment definitely, because that is the primary reason they have come to us. So definitely what ma'am is
saying. It should be side by side. It should be side by side.
Okay. Yeah. Ma'am, yes, I don't know about these. For an adolescent, I would not be going much of tests and all, but a random blood sugar, that definitely I would advise them. A routine hemoglobin, and then both the partners screening and treatment of both the partners have to be taken care of, ma'am.
Yes. And what do you think? What should be the approach, as probably Dr. Pavika wanted to know?
Ma'am, I think so syndromic approach, everybody knows that yes, we have to, everybody has to have that healthcare provider has to be taken care of giving a syndromic approach where we are treating the entire spectrum of sexually transmitted disease at one stop in a single go to our patients.
Yeah, the syndromic approach is one of the most important approaches. And as you rightly pointed out, investigations don't have to be, we don't have to focus too many. We can definitely go for syndromic approach, which is but the only thing here is just wanted to, I think Dr. Neeta and all the experts will agree about it, that presently there is a changing WHO recommendation also, they have now the advisory body. They have not yet, I don't know, we have not yet started implementing. Advisory board group meeting reviewers and updates on STI treatment have recommended in the lights of recent developments. Like if you remember, initially there was the 1991, there was a management of STIs with the contest of HIV and STI control and prevention. 2001 and 2004, they came with the new guidelines under which we are presently doing all those syndromic approach where there are different kits, grey kit, yellow kit, red kit, black kit. I mean, like that we know everything. But now in 2016, they have come out, again updated their concern, their strategy, because they want to end the STI by 2030. And their new guidelines, they do say the approach to individual infections moving away from syndromic approach. Although I 100% agree with you, presently we all are doing with the syndromic approach because our limitations in the developing countries where the facility, we ask them for investigation, then it will become difficult. But of course, we can think there are certain persons who are who have the approach availability and who can want to go for investigation. There we can take that individual approach also. I think Dr. Anita being the president.
Yes, ma'am. I'm very happy that you highlighted regarding screening for HIV. If I may widen the horizon, it is prudent and logical to screen these patients for other sexually transmitted viral infections like hepatitis B surface antigen or SCV, which can be, another component. Of course, this is beyond the scope of current discussion, but we should keep it in the back of our mind that these adolescents, they deserve screening for HIV, HBsAg and SCV also, because these viral infections may also get transmitted through sex. And advising them safe sex is very, very important. Yes, ma'am.
And Anita, Dr. Anita, I will agree with you. This is the opportunity also to, when you are investigating overall, then you can easily approach for these investigations, HIV, HCV, HBV, because otherwise they might become conscious. So this is, in general, you can take up. So that's a very important thing.
Optimization Optimization of health conditions is also important, because whenever adolescent is come, we are looking at the adolescent in a whole health has to be taken into consideration. So that is a very good opportunity.
Yeah. So just give a brief. Very, very brief about just touch upon those syndromic kits, the kits which you have to take because we have to consider the time also. Yes.
So WHO has, given these guidelines for syndromic management. These color-coded, these kits are available. They are provided through NACO, National AIDS Control Organization. The centers, the HIV counseling centers in all the healthcare facilities, wherever there is a screening mechanism exists, like we have Suraksha clinics in our hospitals. It is, focused clinic for STI screening. Then we have HIV counselor room also, where screening is done with pre-test and post-test counseling. And if we are not able to get NAT test done, as usual in all the government facilities, we are giving these couples the syndromic management, like for urethral discharge or cervical discharge. If you can't get, even sometimes they will refuse examination, you can provide them with grey kit. If the patient is presenting with vaginal discharge, you give them green kit, and you can bring the partner also along with that. Similarly, if the boys are coming with other, I'm not talking in detail, like inguinal BIBO is there, then you have to treat the male adolescent also, ulcer disease, then you have the orange kit, then ulcer disease. So you have color coded. You can paste this poster in your counseling rooms, in your OPD rooms, and these are very, very easy to administer, and they are readily available in all the Suraksha clinics or STI clinics of those particular hospitals.
Yes, very nicely you have pointed out this. So, Pavika, will you take up the further?
Ma'am, can I add one line over here?
Yes, Dr. Neeta.
Amrit,
Dr. Amrit.
Yes,
Yeah.
yes.
Ma'am, these are the syndromic approach that we are using currently. But the latest CDC guideline, they have little bit advanced over it, like for chlamydia. They are giving the first line treatment as tablet doxycycline 100 milligram for 7 days. They say the RCTs, they say the studies they have shown that it's better than the azithromycin single dose. But when the compliance is in, we do not like the patient may not take it, then we give azithromycin 1 gram. And similarly for gonorrhea, and because of the resistance, they are moving on to the other drug. Like they are moving on from cefixime to ceftriaxone single dose 500 milligram. These are the recent. No doubt this is relevant in our situation, but we must know the latest what is recommended by CDC.
Yes, madam. Yes, madam. So, Pavika?
Yes, ma'am. So this question goes to Ragini Agarwal, ma'am. Now, how will you treat this case, this particular case?
ट्रीटमेंट तो हो गया है, ट्रीटमेंट में बचा क्या?
Yes, ma'am.
So basically, the two things I want to say at this time, before treatment, just jumping to the syndromic approach for every patient, specifically in the private practice when we talk about, at least we have to try to diagnose it. And as Dr. Mala Srivastava has said, cervical swab or rectal swab, for those things we have to go, and many a time everywhere NAT is not available. So we can send for the gram, at least for the gram staining and the culture to know the susceptibility of the drugs. And as immediately before this question, one of the panelists have beautifully answered that the guideline has little bit changed. One, that doxycycline, our own gynec for very, very favorite drug, we have to give it twice a day for 7 days, or azithromycin that we can give in a pregnancy also. And the second thing is in gonorrhea specifically, what I always prefer, because I'm not very sure how many medicines she's going or not. It's a wonderful to give a 500 milligram IM ceftriaxone injection once, but somehow the dual therapy is more coming because of the resistance, because of the reinfection, or gonorrhea is very notorious because it leads to a systemic infection and it reappears. So I think initially Mala has said this thing that we call again after 3 months these patients. So these patients can go for a dual therapy along with the ceftriaxone. We can give them the azithromycin. And one small thing, always when we have this patient, we should not lose the window of opportunity for one thing, to tell them use condom, and use condom.
Very rightly. So, Dr. Ragini, in fact, you said, but you added so many new points to it. And with your level of experience, that individual thing also, management becomes of this case very important. And as this case was showing the chlamydia and gonorrhea, so your treatment, as you said, is very correct. So now, very rapidly, I would like from Dr. Amrit, Madam, that what are the 5 P's, because the audience also have to know it, besides all of our experts, that what are the 5 P's in the approach of the STI?
Yes, ma'am. The 5 P's are basically for taking a detailed sexual history of a patient when he or she comes to us. And the first and the foremost is the partners. We have to ask, we have to go stepwise, not straight we jump onto the partner. Slowly we have to make a rapport with the patient. Only then we'll start these things to we ask after some time developing a rapport with the patient. So partners, we will have to ask what is the gender of the partners, whether it's male or female or some transgender person, whether having multiple partners or single partners, And the second P is the what practices they are using, like which type of sex they are doing, like it's oral, it's vaginal, or it's anal sex, and with the use of contraception, like braided contraception or not. And then the third P is the protection from STIs, whether they are aware from these, like these STIs, they occur from the sexual contact. If they are aware, then are they getting tested from any doctor or any site? And past history of STIs, like past, anytime he has been or she has been diagnosed with STIs or having got treated for that, and it's worrying him. And finally, whether what is the intention of the pregnancy, whether they, the couple, the partner, they want future children, and if they want, it's okay. If they do not want, they have to take precautions. So to go along by these 5 P's, while taking a detailed sexual history, this will give us the risk, how much risk that person is carrying, and how much protection that. Accordingly, we can manage this question.
Yeah, so basically the most important things in this becomes now, like you have 5 P's, so you remember, you don't miss out anything. That's the very important thing. Dr. Pavika, you continue.
Yes, ma'am. Is Meenu Vash ma'am is there, or if she's not there?
No, she's not there. So someone next can
someone can take this question. What does one-stop shop mean? Anybody?
Can I take that, ma'am?
Yes.
Yeah, one-stop shop or one-stop center means it is all the services are being provided under one roof. So, you know, adolescents as such are very shy to come to clinical establishments. But if he or she gathers that, courage to go to a clinician, all the services should be provided under one roof. Like the counselor should be there, the psychiatrist should be there, STI counselor should be there, the lab facility should be around, so that, the adolescent does not have to rotate here and there, because they need a lot of privacy, they need a lot of confidentiality. They usually have not shared these problems with their parents or their close relatives. So they just want privacy. And if we are going to provide them all the services under one roof, it will be very adolescent friendly. So that was the concept of starting these one-stop shops for these adolescents as adolescent
right. Yeah, so rapidly we go to the other person. Dr. Mala, would you like to tell us what services do gum clinics offer, and actually what is the difference between one-stop and gum clinic?
Medicine. Gum clinic means genitourinary medicine, and for the gum clinic, the adolescent and young people are welcome. They need not come with their parents. They can come alone. They offer testing and treatment for STIs. They give advice. During the gum clinic, you get the advice and information about sexual health. They provide free condoms, advice regarding contraception, also emergency contraception. And they also provide emergency contraceptive pill. Pregnancy testing is there, HIV testing is there. There is a scope for post-exposure prophylaxis that can help people from developing HIV if they have been exposed. Then hepatitis B vaccination. They also help sexual assault survivors, and if necessary, refer to a specialist. And they keep the record very confidential. They do not share with either their parents or their friends or anybody else. They also provide advice regarding abortions and help for sexually assaulted. So this is a gum clinic, which is a comprehensive clinic, but as Dr. Anita said, one-stop clinic for all the purposes.
Yeah, so as I think all experts were pointing out one or other thing, here comes that thing, everything, that HIV counseling part, the how to help these sexually assault persons.
Right. Yeah.
So all those points which by now they were going through every expert's mind, they are covered here. That's a very, very important thing. So, Dr. Pavika?
Yes, ma'am.
Go ahead.
Yes, Vita Gupta ma'am can take this question. What are the 5 WHO goals for STI prevention? What are the WHO goals for STI prevention?
Thank you, Pavika. WHO has made some goals with the intention to, finally make this sexually transmitted disease not a major public health hazard for the entire global. So with this, they had taken 5 things into consideration. They had planned that 2018 as the baseline. So the next, by 2030, there should be a 90% reduction of Tripona pallidum as well as gonorrhea. And they have said that HPV vaccine should be integrated in the national programs of nearly more than 80% of the countries. And so this will take care of your gonorrhea, Treponema pallidum, as well as HPV, accounting to nearly 90%. The remaining thing was syphilis. So they said that the cases of congenital syphilis would be decreased. As a result, your chances of syphilis at the whole global incidence would also be decreased. This was the aim, so that the vision was of WHO that the entire STD should be, finished in this
2030.
Yes, 2030, ma'am.
Very rightly, Dr. Mita, you've said everything. Just an opportunity to mention here is that you all know nanovalent, the HPV vaccine has come. So that is very important because it is covering almost so we get this opportunity to counsel them about that also, that it is preventing almost 7 cancers. And another one thing which recently in the April, there was a meeting at the World WHO level in which they are thinking of advising even that 1 dose might be sufficient, because probably only after that 90% national coverage is possible. So I thought to point it out here that even those are in the pipeline to come in the next.
And we are going to come out with indigenous HPV vaccine also.
Yes,
the company which was making COVID vaccine for India, so quickly they developed and distributed. They are coming up with HPV vaccination. So I think it will be good for our adolescents.
Yes, and Dr. probably now the world after the COVID has recognized India's capacity of developing the vaccine. So we should be proud of it that we are, as you rightly said. Pavika, please go ahead.
Yes, ma'am. Anita ma'am can take this question. What is comprehensive sexual education and how it should be done?
Yes, comprehensive sexual education will deal with all aspects that have to be counseled. You have to be a very, very good counselor, which usually all gynecologists are. Your counseling skills have to be, brushed. You have to use gather approach. You have to use heads assessment. So you take a detailed history, see their even socio-economic aspects we have to take care, why they are indulging in sex and where they are, what is the history of partner, how many partners the partners I have already highlighted. 5 P's we have to use. All these things have to be taken into consideration while taking the history, and accordingly you have to do their cognitive, emotional assessment along with their physical examination and socio-cultural. I have already discussed.
I think he wants.
You have to give age-appropriate education. Like if a 9-year-old is
part, where do you want to give it? And those points, history examination. We have discussed.
In the schools also.
That is what.
School health education, wherever you cannot.
Physiology and the
opportunity. Opportunity is always there.
Dr. Pandey, time to wind up.
Yes,
time to wind up.
Okay, Dr. Sharda, we'll finish up. So that is what I was saying. So just let's, Dr. Ragini, what are the common consequences? Let's be just point-wise quickly so that we can finish.
So, Dr. Kiran, this question can only be answered like this, that whenever we go for anywhere, this sequelae should be always in our mind. And when we talk to our adolescent, what is the sequelae? what I used to tell them, there's two things जो चुपचाप आपकी जिंदगी में आती हैं, आपको मालूम नहीं पड़ता है. एक है प्रेगनेंसी और दूसरा है sexual transmitted infections. And we all know that pregnancy in a teenage girl can lead to the unsafe abortions also. And this STI can lead to the infertility, pelvic inflammatory diseases. So we have to be very, very careful to always take this window of opportunity to tell them about these sequelae also.
Yes, I will take very short because Dr. Sharda has said that's a contraceptive. Dr. Mala just point out a little bit which are the best contraceptives.
Best is to give, advise them condoms. But the problem with condoms is there's a failure rate of 18%. LARC is good for the adolescent because we can advise them LARC, and there's no point in withholding LARC from our adolescent girl who are in regular relationship. But we have to tell these girls that with LARC, there is a chance of STIs as well. So even if they are using LARC as a contraception, which is a very good contraception, they should use condom to prevent themselves to save themselves from STIs. So dual use LARC as well as condom.
Okay. So just Dr. Meeta.
Yes. Use of intrauterine devices. The myths are there with service providers that intrauterine devices cannot be inserted. We can very well offer these adolescents.
Yes, we can use
insertion of any contraception method.
Yes, so that into the long acting also actually they become a part of it. So
just one line, ma'am. We can always advise a dual method. Like if they are using condom, because of the typical use failure rate is high, up to 18%, we can give them a EC pill course with them. In advance, we can give them.
Can I just butt in? Okay. Can I just butt in?
Yeah, Dr. Ragini, I wanted to bring it you also also discuss headache assessment in short because we have limited.
Okay. It's a very important to discuss the headaches, and Kiran, we should not confuse this HEAD triple S with HEAD triple SED because it is very different. When we talk about the headache assessment, it is an internationally recognized tool used to structure the assessment of an adolescent patient. When we are talking about the ED, it is a mental screening tool in the emergency department, and it has 3 values. So we should not confuse here. HEADSS is a home, education, employment, activities, drugs, sex and relationship. And these last 2 S's added here instead of the ED is self-harm and depression and safety and abuse. The most important thing is that when you talk about to an adolescent, you have to build a rapport because it is not easy to them to be open to you. And you have to tell them that a confidentiality factor is very important for them. And the second thing which I want to add is my journey for the adolescent, which started with the 2006 when the first time the India has brought the ASHRH, and we learned one word, non-judgmental attitude, and not to talk to them like children. So when you're talking about the headache assessment, you take them an individual as a patient. Your attitude should be totally non-judgmental. Only then they are open about their relationship, their sexual behavior. And this is very important to discuss to find out whether they are getting some sexual abuse or any other thing. So you have to start your conversation from the smaller question, build a rapport, go in the deep from the home to education to activities, to drugs, smoking, alcohol. That is a very, very important thing to talk to them. And actually, the main thing which we want to see about their depressions and the self-image quotient and other type of abuse. Just to summarize in one line, it does not necessarily have to be completed in one sitting. It may take multiple conversations to build up the trust for the young person.
Very good. That is what I was focusing. Great rapport has to be developed again and again. Lots of confidence. Before I take the final word, just Meeta, one word about Rashtriya Kishore Swasth Karyakram. And then we take the final opinion.
This is one of the schemes that has been launched by the Ministry of Health and Family Welfare with the basic, because of this changing trends of the newer adolescents. This was the newer integration they had launched in 2014. They wanted to look into the sexual health of the patient, the adolescent health. Basically, adolescents have the basis of this program, and the entire aspects, the anemia, the sexual health, the nutritional aspect, the education, everything is taken into this thing, ma'am. So this was...
Yeah. And more, madam, I just want to add one line that RM and CH program was there. That was regarding reproductive and maternal health. Now it has become A. Now we know the importance of adolescent health. So it has become RM and CH plus A. So that is also very
correct. Very correct. So now just one word from each, not the detail. How do you think, the last question is this, from every panelist should give their one-line answer. How do you think that we gynecologists can promote adolescent health? So that is the final thing. I want everybody to add up something to us. How do we?
So, ma'am, counseling, only counseling.
Okay.
We should not miss any chance whenever we get in communication with our citizens. You have time
from my side, Dr. Kiran.
Comprehensive sexual health education. That is the most ideal.
The only thing I can say, the window of opportunity, always remember adolescent health is not something that you are going to give to adolescent, because most of the time no adolescent is going to come. Maybe that adolescent has come with a mother, or that mother has come for something else. So this window of opportunity should be used for the promotion of the adolescent health in the community and everywhere.
And every clinician should be a very good observer. Whenever you are dealing with an adolescent patient, get those subtle clues that the adolescent wants to share, because there may be 2-3 patients standing around you. So give them opportunity, give them privacy, give them share that their conversation will be kept confidential. So
and basically non-judgmental environment.
We have to be
non-judgmental.
Yes.
Yes. So ensuring privacy, non-judgmental environment has to be created. Yes, Dr. Mala, you want to give someone?
We have to be non-judgmental. We should not give them advices. Don't do this, don't do that. They have come to us. They have come for treatment. They have come for... So we have to respect them. Give a lot of respect to them, because it's good that they have come to a gynecologist and not gone to a quack. So we have to take this opportunity, listen to them patiently, treat them, and definitely take an opportunity of window of opportunity to guide them.
Yeah, thank you very much, Dr. Mala. What I wanted to say, the most important thing, changing our attitude. Also, even today, most of the gynecologists in general will start saying with this, don't do this, and why you have done this. So we have to be non-judgmental, respect their things, and at the same time with gaining the confidence, then explaining them what are the side effects or what are the problems can they go into, and then only we can give them this. So thank you very much.
One important point we are forgetting. It is okay that these girls or boys that are coming to us, they're sharing the problems. Very subtly, we have to, apprise them of our existing law of land. We need to, apprise them about FOGSI also. We cannot deny them services, but we have to very gently tell them that, currently we are living in India and sex before 18 is illegal. So we cannot be directed, we have to just give suggestions.
Yes. About that we will discuss about FOGSI, but then I thought let's keep
just
it respect the time limit also and the other things. So therefore I thought let FOGSI is a different aspect, but of course you have to keep it in mind. Very rightly pointed out, and very much. So I really admire everybody's view, concern for the adolescents, And the most the important, I would again say, Dr. Sharda Jain, Dr. Sadhana, Dr. Ragini, and everyone to give us this opportunity to be the part of this academic series. Dr. Pavika, who has actually worked a lot hard on this, because I is not in India, so I could not do much. She has taken. Dr. Pavika.
Yes, ma'am. Thank you so much, ma'am. Thank you. Thank you.
Thank you. So all my panelists have given their expert views, and you have enriched our knowledge also. So now let's go for experts.
Kiran ma'am, thank you so much. Ma'am, Kiran ma'am, just on the behalf of us, the panelists, we want to thank both the moderators. Both of you, you have really brought us the expert comments from everybody. Thank you so much, ma'am. Thank you, ma'am.
Thank you, Dr.
Thank you, Pavika.
Really.
Dr. Kiran, Dr.
Madam, stop sharing, please.
Yes, ma'am. Yes,
okay. So I think, Madam, you would like to give some expert comments, enrich us with the further knowledge, or our experts of this. Are there any experts in the panel also?
I will say, adolescent health is very dear to my heart. And I started it at a time when there were no experts on adolescent health was available. I got an opportunity of training hundreds and hundreds of doctors in adolescent health through IMA. And I feel, this is what is needed. I have a little difference of opinion when you talk about heart and putting an IUCD. It means you have never worked. You're only talking practical. You are talking theory. आप मुझे अपने प्रैक्टिस में बताइए किसी बंदे को आपने आईयूसीडी लगाया? हम फ्रांस नहीं है, हमें हिंदुस्तान की बात करनी है. और every time my request to everybody is every academic session must be timed and everybody should finish at that particular time. When you're in a panel discussion, when you're talking about it, when your turn comes, you should speak. If you increase your comments like this, then you will find that your time will definitely spread and we go beyond time. So my request to future panel is that be in time and we must talk. We are in India. We must talk about India. People like us are pioneers in adolescent health who have conducted workshops in medical college, engineering college, Delhi colleges, everywhere we had gone. And we know what the practical part is. If you're not practical, if you don't give life advices to them and do a courses, things of this particular kind is not possible. इतनी बड़ी पैनल थी, मुझे बताइए किसी ने आईयूसीडी लगाया है? बोल रहे हैं हम लोग.
Patients are asking for it now. The girls are coming and asking for it.
Are asking. The girls are coming and asking
because they come, they Google. And they come with the knowledge and they come and ask for it.
Even, ma'am, I had Asha gathering yesterday. Of course, ma'am, those, even Asha workers were asking. Yesterday we had a meeting, they said, can it be inserted? Because somebody might have asked them also. So I was just giving a reference that it is a myth that it cannot be inserted in a sexually active adolescent. That was I wanted
to is there. As a gynecologist, we cannot say that you use this thing. Counseling is okay, but if you are putting a Mirena or something IUCD, you are saying that yes, you can go and have a sex. That is equivalent to a rape if a girl is less than 18 years in India. Yes. So we have to be very careful what we are doing and what.
Very true. Very true.
Also, मैं आपको बताना चाहती हूँ. I remain chairman of Max Hospital. मैंने एक पेशेंट का एडोलेसेंट का एक यूरिन प्रेगनेंसी टेस्ट करा दिया. तो उसका जो फादर बैठा हुआ था, he went to the CO and said Dr. Jain has asked for a urine pregnancy test. We are working in those times. So be practical what you're talking about.
Madam,
the discussion had been absolutely great. I will say that the panel was absolutely wonderful, and less is said about the madam's presentation on adolescent PCOS. I think it was just wonderful.
Thank you very much, madam.
Thank you very much. And
very important for us.
Thank you so much, ma'am. Thank you, Dr. Shada Jain, ma'am, for your final comments. And I am sure next time we will be very brief and to the point and up to the time. So that we have to keep in mind for our next webinar.
Yes.
And over to Dr. Meenakshi Sharma for the vote of thanks.
Thank you, ma'am. The world is full of diamonds and gems, and we are having some of them today in our first successful meeting of North India Gynaecologist Forum. Respected Dr. Shadajan ma'am, Dr. Sadhana Gupta ma'am, and Dr. Ragini Agarwal ma'am, and all the stalwarts and dignitaries who are present here today in the meeting. I really feel honored and privileged to propose this vote of thanks on behalf of N.I.G.F. I express my gratitude and sincere thanks to all the experts today for a very informative and successful academic session today. And I would like to thank all the known and unknown hands that contributed for the success of today's program. And a big thank you to Team COR CONNECT for providing the platform for the meeting. A good event never ends in the world. They take only a pause and keep us awaiting for the next. So our next meeting is going to be on 3rd Friday of this month. We are all happy and grateful for this successful program today and hope and wish for success of our newly formed organization. And on this platform, I want to say that please, I'm requesting every one of you to please circulate the form, which is available online link or to the Google form for the membership of the North India Gynaecologist Forum. So please circulate among all your friends, all your professional groups, so that we get more number of members in our organization. Today, as of now, we have around 450 members who have filled the online form. And more than 150 are from Delhi and the rest are from other states. I can give you the breakup also. But I just request everyone so that by the time of the next meeting, we have more number of members and we achieve a target of 2,000 members in the next 2 weeks at least. Thank you. Thank you.
Please mark the date 5th August. We are going to have our next program on the 5th August.
That's right.
Thank you.
Thank you. Thank you very much, madam.
Thank you. Thank you.
Thank you, Dr. Malik, for you. When you are a moderator, you have to see to it that you will keep things to the time. I should not be speaking next time.
Yes, madam.
Thank you, ma'am. Thank you, ma'am.